been a supporter and friend of ACV since our inception in 2017. And he's also on our advisory council here. And Dr. Cole is currently the medical director for Kindred Hospice. He'll tell you a little bit about that when he starts speaking. But this was a request from people in some of our support groups that we have someone involved with hospice come and talk about the difference between palliative care, hospice, and everything that goes into that whole concept. And there's no one better to do that than Dr. Cole. So I'm going to turn this over to you now.
Okay, good morning, everybody. Can you all hear me? Yes?
Yes.
Great, okay. So my background is that I'm a family practitioner by training. I had from 1998 until I closed my practice in 2011, I had a solo practice in Palm Springs. In 2011, I became also board certified in hospice and palliative care and was the medical director for a large hospice agency. And under that agency, we also had a large palliative care program as well. So, and right now I do work with Kindred Hospice. I'm one of their medical directors. And also I work in the skilled nursing facilities for people who are living there long-term and also who go there for rehab to get better and come home. So that's kind of my background, but I am board certified in family practice and in hospice and palliative care. So the discussion I was asked to talk to you all today about was what is hospice, what is palliative care, talking about people who have a terminal diagnosis, terminal meaning what length of time, and that's partly what we're going to be talking about today. Palliative care typically is for someone who has a life-limiting illness of some sort with probably around 3 years or so still in of life. And so the main goal for hospice or palliative care is primarily focused on being comfortable, having a good quality of life, and not spending inordinate number of hours at a hospital or running around to a bunch of doctors, having a lot of procedures and hospitalization. So the idea both with hospice and with palliative care is to provide that care in your home where people live, rather than having to go in and out of hospitals and doctor's offices and that sort of thing. Typically with palliative care, we estimate around a 3-year or so prognosis. I've had some that were 5 years, so it really just depends on what we call the goals of care, which is basically what do you want for your own life. And if you want to see a bunch of doctors and do procedures and have what we call aggressive care, surgery and so on, well, then that's not palliative care. Palliative care is primarily somebody who says, you know, I've already had all that stuff once or twice. I don't want to go through all that again, but I do want to be as healthy as I can without these more aggressive type of treatments. Hospice is a part of palliative care, but it's for people who have, generally it's defined by Medicare as people with a 6 months or less prognosis. It is not what is commonly thought of people who are going to die in the next 2 weeks. And the old way of looking at hospice and how it was originally brought out back in 1983 was for people who were clearly terminal in the last few weeks of life, and the idea was just give them morphine and make them more comfortable, and then they're going to die. And so many people have a misconception of what hospice is now, because that is not what hospice is now. Primarily in the early days, it was for people with cancer. Now, cancer diagnosis is only about 1/3 of people on hospice have cancer. The other third have other late stage chronic illnesses, whether it's a heart disease, lung disease, kidney disease, some kind of neurological defects. stroke, Alzheimer's. All of those have guidelines that we have been clarified so that somebody is eligible for hospice, not just palliative care. The difference between the two really comes in the definitions as provided under Medicare. Medicare is very clear that it's someone with an estimated prognosis of less than 6 months. And this is around the time when I say, and my dad was on hospice for 2.5 years. So there is no exact only 6 months. You only get 180 days of hospice in your life. There's a recertification process that occurs every 2 to 3 months where we look back and say, gee, does somebody still eligible for their Medicare hospice benefit? And starting today, do we think they're 6 months from today, not 6 months from when we started? So hospice is completely covered by Medicare under Part A. And if you don't know what that is, that's the hospitalization part of Medicare, rather than the Part B, which is if you have a supplement, your doctors and outpatient stuff. And it is 100% covered by Medicare. Palliative care is not at all covered by Medicare in any way, but there are some programs that are funded typically by insurance companies who see the wisdom in providing care at home to keep people healthier, so you're not in and out of the hospital and costing a lot of money. And they say, gee, it makes more financial sense to help people in their own home, saves us money, they're healthier, they're happier. So palliative care coverage is a problem. It is not currently covered under Medicare. So if you're eligible for a palliative care program, it depends on actually who's going to pay that. And that's one of the things that is being worked on in the government levels with the agencies and the national organizations and so on. But right now, a palliative care program is only paid for by certain insurance programs, and that becomes the problem. What's covered typically in a palliative care program is that a nurse will typically come to the home and confer with a doctor over the telephone. Rarely does the doctor come to the house, but they can, depends on the program. Typically, they also have access to a social worker as well that can help clarify additional in-home supports and other insurances or other legal matters to help coordinate that like a social worker would. With a hospice program, it comes with a Medicare defined team. The team includes a doctor, the nurse, a social worker, and a spiritual counselor, and a dietitian. So those are the disciplines that are required to be covered under hospice. And those services are typically available through a palliative care program, but it's not, there's no defined requirement. Unlike hospice where it's defined and every hospice agency provides these different programs to help. Typically on hospice, the nurse will come out to the house once a week, more or less. It's a minimum of 2 times a month, can be 2-3 times a week, depends on what the patient needs in the home. Typically on a palliative care program, the nurse comes once or twice a month, just depends. And then they are also available by telephone call and can make as needed visits. All that depends on how the palliative care program is organized. Palliative care programs have to be operated under a hospice license of some sort, and they have access to that. And it's a little kind of dirty secret that some palliative care programs are basically feeding programs to the hospice agency, and that's how they fund them. So palliative care has the hidden aspect of the money, who's going to pay for it. Let's see. who determines whether it's whether someone needs hospice or palliative care? Typically, that is a joint decision by the family, defined as what is it that you see for yourselves? What do you want your care to be? How aggressive do you want care? And if primarily you're looking at, well, yeah, I don't mind going to the doctor once in a while and I want to take my medicine and do as good as I can, but you're not going to die in the next 6 months, then you may be appropriate for a palliative care program. It's a joint decision between a doctor and the patient, if you ask me. With a hospice program must have a referral from a physician, from a doctor, and also a hospice doctor needs to review the case and to agree that the individual has a prognosis of less than 6 months. And the family or the patient will be saying, yes, this is what I want. I don't want any more, let's say, chemo, or I don't want any more maybe dialysis, any more hospitalizations or ventilator tubes and things like that. And so it's always a joint decision by the patient and the family. What do we want going forward? And then the certification process for hospice. So it's a joint decision. Let's see. We've talked about how it's paid for and the services provided. One of the questions that was asked of me earlier is that, what if I'm on hospice and I'm not dying in 6 months after all? What's the next step? We have patients from time to time that say, I was doing really, really bad, but now I seem like I'm pretty stable, so maybe I do want to go back to my other doctors and have more aggressive care. That is always an option. Hospice is one of these things that you can decide today I want it, and tomorrow you can say I changed my mind, and then come off. And that's called a revocation. Means I decided I don't want this hospice anymore. I want to go to my regular doctors. And that's always an option. And then 2 days later or 2 years later, 2 months, you may say, I've been to my other doctors. I'm not getting any better with them. After all, I'm starting to get worse. I want to come back on hospice. And that's always an option. There is no limit to how long someone can be on hospice within their life, or that you have to stay on when you sign, or that you can't come off. It's a decision that can be made actually on a daily basis if necessary. So what happens if you have decided you want hospice, but you are not satisfied with the services of the agency that you're on? Patients always have a right for choice. And so your option is to say, well, I don't want hospice at all. Or you can talk to them and say, gee, I thought we were going to do this and this and this, and that's not happening. And then they can either fix it and provide the services you want. They may tell you, well, if you thought we were going to come to your house and basically move in and take care of your loved one, that's not something that hospice provides. They do send a home health aide, typically 2 or 3 times a week for a couple of hours to help with personal care and bathing and maybe a little bit of light laundry, changing bed sheets and so on. But they're not what we call caregivers, where that's not something that Medicare allows. And in fact, if a hospice agency starts doing that and Medicare finds out, they can come after them for what's called inducement, which means, oh, we'll give you a bunch of stuff that we're not allowed to give you because then you'll sign up with us and we'll get the money. Medicare doesn't like that at all, and they will actually come down, shut them down, and put them in jail. So, if you decide you aren't happy with the services, you can say, well, I thought I was going to get this. And then if you work it out, fine. But if you say, these people are nasty and I just don't like them, but I want hospice, then you can transfer to a different hospice. There are a number of hospice agencies in the Valley. We have probably about I'd say 5 that are on the larger size, near 100 or more patients. And then we have a number that have a very small number of patients, 10 or 20. But there are, near as I know, at least 15 different hospices operating out of the valley. But like I said, there's about 5 that are the larger ones. But you always have a right, the privilege of choosing. I don't want to date this person anymore. I want to date somebody else. Okay. It just didn't work out. Sometimes you can have that discussion and clarify things. And more often than not, with open, honest communication and good discussion, typically the issues are resolved. But if you're not happy, there's always the choice to say, I don't want hospice anymore. I don't want this agency anymore. And you can make your choices. How is a hospice agency chosen? That is absolutely a patient's and their family's choice. Typically, a referral would include 3 different agencies, but you can find out from other people. You can look in the phone book, you can Google hospice local and see what happens. And then you can interview as many people as many agencies as you like and say, gee, this one seems, just right for me. So I'll go with this agency. But the choice of agency is always up to the patient. Another little secret is that there are some doctors who are connected with a certain hospice, like I am. And it is absolutely against every regulation for them to tell you, you have to go with this hospice because that's the one I'm in. What I will tell people is I am exclusive by my contract with this particular hospice agency. If you want me to be your hospice doctor, this is the only agency I work with, but you have a right of choice of any other agency that you like. And so then sometimes the patients will choose a different agency and sometimes they'll choose the one that I'm with. But if a doctor or a case manager or nurse anywhere tells you you have to go with this company, that is not factually accurate. Patients always have a right to choose which agency you want. Typically, the case managers will give you options if you're in a hospital or a skilled nursing setting. But yes, the provider choice is always up to the patient and their family. The last question that I was given ahead of time is terms of service. And basically, Medicare defines hospice as people who have a life expectancy of less than 6 months. However, as I mentioned, that is reviewed every 2 to 3 months, and that 6-month period starts from the day of review. The hospice team meets every 2 weeks to discuss all of their patients as a team. And part of that discussion is if somebody's been on for 2 or 3 months, is it time to recertify them and how are we going to do that? So that there is no limit on the number of that they're called benefit periods under Medicare. There's no limit to the number of benefit periods. And as I said, my dad was on for 2.5 years, which is quite a long time, a lot more than 6 months. But anyway, so those are the kinds of questions that I was given ahead of time that I wanted to address. Those are basically, the differences between hospice and palliative care, kind of, hospice palliative care 101. But my style is to make the little presentation up front. Then I'm more than happy and prefer actually that you ask me questions that are important to you, and I'll give you the best answers I can. And the best question is the one I know the answer to. So go ahead and ask away.
All right, thank you, Dr. Cole. If you have a question and you don't feel like voicing it out loud, please feel free to put it in the chat and we will read it. But you may unmute yourself and ask questions. We do have one already from Mary Kay in the chat, and she is asking approximately what proportion of palliative care is paid for through an insurance company versus private pay, and how much does palliative care cost in general?
I don't know any palliative programs that accept private pay. I do not know what the daily rate is for that, so I can't answer that question.
Okay.
And what was the percentage? What was the first part?
Well, asking what proportion of palliative care would be paid through insurance, but you're saying that you don't know of any insurance that would pay for it.
Yeah, well, there are some insurances that pay for it if you're one of their members.
Okay.
And so in that case, typically 100% is paid for if you're eligible for that program. That's one large company here in the Valley has a palliative care program, and for their members, that's 100% paid for, is my understanding. But you have to be eligible for that program and be one of their members. I'm aware of another program that is run by a hospice company, and I also believe that for that, that's also probably 100% covered. I don't know that as a fact, but that one is with an expectation that in a short number of months, you will go on hospice. What they're really looking for is someone who is appropriate for hospice, but personally isn't ready for that yet. And let's just say they want to date a little bit for a couple months first, make sure that they're coming along toward understanding that they really do have a 6-month prognosis, but they were just not quite ready to say, yes, I'm ready for hospice yet. And so those are the two that I know of in the area.
All right, thank you. And Dr. Cole, can you tell us which hospice you are with?
Yes, I'm with Kindred Hospice.
Thank you. Okay, our next question from Mary Lou. She's asking if an assigned nurse or other hospice team member is not easy to reach and doesn't give family members updates as requested, how should the family handle it?
Okay, well, in that case, first thing I would do is speak to that nurse. I guess it's the nurse you're talking about, is asked to either speak to the social worker on the team and express your concerns that you're not getting your needs met, or to speak to the manager and say, you know, this a particular person doesn't seem to be getting back to me as I would like, and see what can be resolved. But yeah, I would either contact the social worker, because a lot of times the social workers are able to negotiate things through the process, and sometimes it's not the nurse that's supposed to be. It's not the nurse that has the knowledge that you're looking for. It could be somebody else. And so the social worker is very helpful because they have a total picture of the case. And the nurse is more narrowly, as appropriately he should be focused on the medical care. So either the social worker or the manager is where I would go next. And if it just doesn't work out after that, as I mentioned before, you have a choice of agencies and you can do an agency transfer. We get those all, on occasion. We get the people coming to us because they're unhappy somewhere else, and we get people leaving us because they're unhappy with us and they think that it's going to be better somewhere else. And so they're always welcome to go find the green grass wherever you like. Sometimes it's just not a good fit.
Thank you. Do we have any other questions from our?
Yes, this is,
I do.
yes.
Oh.
Or does John and Helen want to go first?
Diane, why don't you go ahead since you're
Okay.
unmuted, and then we'll.
Sure.
Helen.
Yeah, thank you. Gosh, it's always, thank you, Dr. Cole, for presenting. I have such a passion and love for hospice, so always like to talk about it. I actually hired into a Kaiser Permanente hospice back in the 1982. It was a part of a demonstration project. Yeah, so way
That was experimental almost.
Oh, it was. There were 3 demonstration projects in the United States, and Dame Cicely Saunders came.
Oh, wow.
Brought some of her physicians and helped to teach our physicians how to do hospice.
Yeah.
So very, very special memories that I have of hospice, and it's
Wow.
always to be with the dying is a calling for me. But what I wanted to say is I remember back in the 1990s when let's see, what did you call it? Provider choice. You had to, before you could just, refer to a hospice, but then the provider choice came in the 1990s, and discharge planners had to give people choices. I have to say, I was working at Kaiser Los Angeles, and when I came out here in 2003, it just seems as though they weren't familiar with giving choices. Do you think that has evolved over the time? Do you think they're really giving choices for hospice, or are they just saying, here, we're going to sign you up for this hospice, or this hospice will make contact with you? So that's the question.
Sure. Okay. So they're supposed to give choice. That's a Medicare requirement, and that is supposed to be the way that it goes.
Yeah.
Sometimes people will say, I don't care, just give me one. I'm too stressed. I have so much going on. I only just need one. And so then they've presented their choice of I only want one. And then you still get to interview them and decide, no, I don't like this one after all, so give me a different one. Or you can say, yep, sounds good to me. I'm got so much else going on right now, and this will work. Sometimes there are people who have contractual arrangements, and so they can be, what can I say? They can say, gee, I really like you a lot and I want to be your doctor, but this is the only hospice I work for. If you want to work with me, this is the hospice you come to. That's the way I do it. There are some doctors who say, tell the nurse, this is the hospice I work for, so send everybody I know to this hospice. Shouldn't be that way. This is why typically the doctors are supposed to write an order for a hospice consult and evaluation, and it's a little beyond for the doctor to say which agency, unless the patient has said, I want this agency, and then we clarify, I clarify, the patient has asked for this particular agency, so I'm informing the discharge planner or the nurse, this is what the patient told me. However, they're the ones that step in between and give the choice. That doesn't always happen. And then sadly, I have heard stories that there are case managers who get gift cards for referrals. And I'll just leave it at that.
Okay, thank
But
you.
yes, you are absolutely correct. In the 90s, they realized some of this shenanigans was going on, and it's very clear that the patients are supposed to have choice of agencies.
Yeah. Okay, thank you, Dr. Cole.
Yeah.
This is Kay Hammond, and I cannot see on the screen because it's set in a driving mode. May I ask a question?
Go ahead, Kay.
Thank you. Hi, Dr. Cole, Kay
Hi.
Hammond. I have a comment for clarification and a question. My comment is, oftentimes a family will say, I'm really not happy with this hospice, but the people are nice, but I don't like X, Y, Z, but I don't want to hurt anybody's feelings. So we always clarify that you simply contact the company that your second choice, and they handle everything. So nobody's ever offended, and at least not, you're not aware that of the change. You're not aware that, let me say, the family doesn't feel uncomfortable having the home health aides change, or having to face with anybody and say, I just wasn't happy with you. So I always found that to be very valuable, that all the paperwork just goes through and it's seamless. Now, my question is, if I heard you correctly, that with hospice, you include a nutritionist?
Correct.
And I can understand why there would be a nutritionist for palliative care, but would you educate me the value of a nutritionist with someone's short life expectancy?
Well, and again, it's a registered dietitian rather
Okay.
than a quote nutritionist.
Oh, okay, a
And
dietitian,
the
yeah, thank
purpose
you.
Yeah, and the purpose for that, let's just say, is to focus on what kinds of nutritional support, what diet is best for the patient. It may be there's some trouble swallowing.
Oh,
So
I see.
we can assist the family with knowing what kinds of consistency of food. We can also realize that if somebody has a potential for skin breakdown, certainly maximizing the amount of protein in the diet is helpful. So if somebody only wants to eat, let's just say, pancakes and cookies, can you sneak some protein powder in there? And so some different ways to nutritionally support the patient so that even though they're dying from their terminal illness, there may be certain kinds of foods that are helpful to support the body even
Wow,
during
that's,
that process.
thank you very much. Makes
Yeah.
complete sense. Thank you very much.
Yeah, and then regarding your first comment, yeah, that's an absolutely way to go, is to have the other agency that you've decided to let the first agency know that the patient has decided to come to us, please send us the records. And that happens on occasion as well. Sometimes prior to that, speaking to the social worker about the issues that are going on can resolve, particularly if they like the caregivers.
Oh, absolutely.
Yeah.
Yeah,
so
no, I
I've had many
understand.
patients who think whose favorite person in the whole team is the caregiver, the home health aide that comes out and gives them a nice bath and does their hair and nails
Right.
and stuff. And so, they really like them, but there's some other issues. Trying to work it out rather than a whole new team is sometimes helpful. But when it's come to the point that I've tried, this ain't working for whatever reason, or I don't even want to try as much as I like this one person, we're not getting near what I thought we should, then you've already identified a different agency and decided to go that way. Having them facilitate the paperwork for the patient and family makes it much easier on the family. And also it avoids the difficulty of saying, gee, I really like you, but I don't like your bosses. So
Right.
have to say goodbye.
Exactly.
Yeah. Very good.
People
point.
are often afraid to even reference any disappointment because they're afraid it will happen. It'll come back on their loved one.
Yeah,
But I
that's too bad.
absolutely agree. I absolutely agree. Thank you.
Yeah.
All right, Helen, would you like to ask Dr. Cole your question?
Yes, I think I have two questions. And the first one has to do with the Medicare. And if they regulate the hospices, then is one able to go to the Medicare site as you would for nursing homes and get some feel for the ranking or how each one of those hospices is
I know there are, I can answer that question. Yes, there are, ratings and so on. Where exactly they are on the Medicare side, I have no idea, because I'm too busy with my life to try and negotiate a Medicare website, but it may be very easy. I don't know. But I know there are reports and rankings and measures that are evaluated. So
by Medicare, yeah.
By Medicare, yeah.
And then my other question has to do with, we're insured through a Medicare Advantage plan. Is there any difference in terms of what the offerings are, et cetera, if you're in a Medicare Advantage plan and you opt for hospice? How does that work?
Yeah, absolutely. I'm glad you brought that up. The way it works in that case, when you're already on Medicare Advantage here, and then let's say you decide I want hospice. So what happens is Medicare under hospice takes priority first, but in the background, your Advantage plan kind of goes on, what can I say, like on idle. It's in the background and it's always there, but it's for things that are unrelated to the hospice diagnosis or why somebody is on hospice. And so that's how that works. Then let's say somebody comes off hospice, then the Medicare Advantage, you go right back onto that, whether you decide you want to do it for yourself or it's been, 9 months, a year later, and the patient is stable, then that's when the discharge for extended prognosis or the graduation from hospice comes in. And then the Medicare Advantage, which has always been in the background, kicks right back in on the first of the next month.
So in other words, you're still a member of your Medicare Advantage plan, but for hospice, your primary is hospice, is Medicare. For
Yeah,
hospice.
well, your primary is actually hospice under Medicare. So,
Okay.
so Medicare says, well, if you're on hospice, we're gonna go that direction first. You know, that's the horse you're gonna ride first. And then if you need to take a side trip somewhere else that the hospice doesn't go, then you can jump on the other horse and go over here for a second under your Advantage plan and then come back.
So you're not disenrolled from your Advantage plan, you're just not using it unless you need it, so.
Correct, you are not disenrolled, it's just in the background, but the hospice agency is the one that's going to hopefully, you know, in conjunction with you and maybe the social worker, is to make sure that who's, you know, is to coordinate all that.
And you still have the same choices, it's not as if your Medicare Advantage plan has a hospice in its network that you have to use or anything, you still, because you're going outside of that network.
Yes,
you have
you
a choice.
absolutely still have choice, as we discussed. Some Advantage plans have an association with a certain hospice, and so they may try and steer you when they're giving you their choices. So there is some of that, but under Medicare, unless the hospice agency isn't Medicare certified, which means they're probably not even going to be in business more than another couple of weeks, that you do have a choice of any hospice you want, no matter if you're on an Advantage plan. Now, sometimes a patient is under 65 and they're on a managed care type plan under their insurance. Those insurances do have contracts with hospice agencies, and therefore, under a commercial plan, not a senior managed care plan, there may be some limit in choices, because then the insurance company has to have a contract with the hospice for those services. But that does not apply in any way I know to a Medicare Advantage plan, a senior managed care HMO plan.
Thank you.
Was that pretty clear?
Yeah.
It's a little complicated, but did that answer your question?
It did. Thank you
Okay.
very much.
Good. Okay.
All right, now Frances said she had a question, but I don't see her right now. Frances, are you there? And here she comes.
Hi, Francis, I see you.
Oh, boy. Thank you, Dr. Cole.
Yeah.
So this is going to be like personal, but I'm going to share it. It's not a general kind of question. Just now, back in about October, well, for about a year, I'm with SCAN and Desert Oasis under that. And for a year, my doctor tried to get me on palliative care 4 times, and it never worked. The last time in about October, the nurse came and he left. He said, no, he doesn't qualify for palliative. Then he called me on the phone. He says he will qualify probably for hospice. So I had my husband on hospice through to maybe February for 3 months. And I didn't like it because I couldn't use my own doctors. And I found out you can choose your own doctors. Anyway, after 3 months, the day that I called family hospice and said, I'm not going to continue, that's it. And they wanted to put him on palliative care. And I don't know what happened that terrible, terrible day, but I was in the backyard with my husband and talking to somebody on my phone. I was talking to somebody on the phone, and my daughter called me and I said, I can't talk to you now. What had happened was, in that transfer from hospice to palliative, they called my daughter in Los Angeles and told her that her father had expired. Anyway, that was settled. And then and because I wanted to use my own doctors, that they put him on for his kidney. He's stage 5 actually, kidney disease. So they had him on kidney. And the day that I wanted to leave hospice, they had switched him to Alzheimer's. And so then he was on for a month, and I just didn't want it anymore. I didn't think it was necessary, because my husband, I've been taking care of him for years, and I wasn't ready for him to expire yet. And so I wanted to be more progressive. I wanted my own doctors. we kept the kidney doctor anyway. I don't know if he's going to get paid or what happened, but you know, he kept us, and like his numbers were down to 12 as GFR, so that was not good. And now I'll see him again next week, speak to him again. Anyway, so at this point, I don't know what to do. The reason I'm so upset now is I have somebody staying with him so that I can be on the Zoom, and he wouldn't take his pills for the first time ever. And he's yelling at me, leave me alone, go out, go in the room. So maybe he's jealous that I'm sitting here and talking to you and he doesn't know what's going on. I don't know. Anyway, so what's my question? I don't know now. He really upset me. So that's interesting to know that, well, the thing I didn't like about hospice was that I couldn't use my own doctors. And then when I found out you could, by the time they did it, I wasn't interested in hospice. It just wasn't meeting my needs. And so now I'm just interested in getting caregivers, which I'm working on. I'm interviewing somebody tonight and I'm trying to keep him home. Well, there's something new for me to say would be keep him home as long as possible. If you asked me last week, I said he would never go into placement. But I don't know, he's getting a little difficult now personality-wise. This COVID has just knocked him out completely. He was a volunteer in a little museum we have here in Rancho Mirage. And everybody loved him and he was wonderful and he went there every day and he was very helpful. But this COVID, without the socialization and the cognitive stimulation, I guess I didn't do a good job, but he's just going downhill so rapidly. I don't know, maybe that was more of a statement than a question.
Well, you brought up a number of interesting points. Number one is clearly this is a complicated situation that you and your husband are in. And there's so many different pieces that are all adding up to just being a bad situation. And that's really, difficult. First of all, I'll just comment on the COVID part. This has been a horrible time for many, many people. The numbers of deaths from suicide and some other, very difficult problems, the social negativity, the negative aspects of the shutdown has been significant. And that's something to weigh. Is it been worth all of that compared to the numbers of deaths and how much did the shutdown prevent? There's a lot of discussion because there's so much about COVID we did not know. And fortunately, we think things are starting to turn around. It seems like the government is letting up on some of the restrictions. But, what's happened to your husband as far as his socialization and his ability to be out and meet people and enjoy, we are all connected to each other in a very important way. And when we are not allowed to see our friends and to meet people and have hugs and you laugh and talk and see smiles, it's just been incredibly difficult emotionally on many, many, many people. Something like 40% of the population of the United States has suffered problems with depression and anxiety because of the reaction to the COVID virus. And 40% of the people in the country didn't die from COVID. So the numbers are just horrible as what's happened as a consequence of the management of the COVID situation. Next is as far as, getting caregivers so that it can relieve you of the caregiver burden. This is very important, and actually through ACV, we have for the Alzheimer's patients, we have the Traveling Together program.
We're in it.
Okay, so whether it's because of, memory problems or any other chronic illness, the burden on the caregiver is huge. And so, I think it's with Pat, please let me know if I think the statistic is 1/3 of the time the caregiver dies before the person with the diagnosis.
17%.
Right, okay. So the fact that you're reaching out and hiring caregivers to relieve you of that burden is important for your own health. And also it gives you the privilege of being your husband's wife rather than his caregiver. And so that is important, and I'm glad you're doing that. That is important for everyone to be aware that that's an option. As far as, you know, you did the right thing. It's like, this hospice isn't working out for me. As far as seeing all of your own doctors, typically when someone's on hospice, the care is managed by the hospice doctors or the nurse practitioners and so on. If it's related to the diagnosis, then brings up a point. You said, well, first he was on for his kidney disease. So then I'm not sure if it was you or them that changed the diagnosis to Alzheimer's.
They did.
They did, and that was because then if he was on for Alzheimer's, you could go see your kidney doctor? Is that why they changed it?
Maybe they knew I was unhappy.
Yeah, because typically if somebody's on for Alzheimer's disease and dementia, but they have renal disease, but they're seeking aggressive care and management from a nephrologist, a kidney specialist, then that would be, as Helen, we were talking about, riding the other horse. That would be outside of hospice, because the patient is choosing to see their other doctor for an unrelated to hospice diagnosis. And so that may be why they did that. I can only guess that the reason they called your daughter and said he died was because somebody said, oh, he's not on my service anymore. So I assume he must have died. I might as well tell the family. And instead of seeing that his wife is the primary contact person, they saw a daughter somewhere and called her up. I mean, that's just horrible for your daughter to have gone through that and then call you and say, what, daddy died? And you're like, I don't think so. I'm looking at him and he's right here breathing, what a lack of communication. Let's just, as kindly as I can say, that was a real mess. So yeah.
Okay, but I'm happy to hear Kindred. I was gonna, was the question I asked before, so that's good. Thank you.
Yeah.
Sorry to take time from everybody. Okay, I'll mute myself.
I think so. What you brought up was wildly important for all of us to know, and it gave me a chance to talk a little bit more about some things we hadn't talked about, and to circle back to Helen's question as a really good example of how do you get to see your own doctors and what does your Medicare Advantage plan do for you while hospice is in front? Well, the nephrologist was in the background in this case. Yeah. So thank you.
Thank you. Thank you very much.
And my heart goes out to you. I know it's difficult, and maybe somebody at ACV can reach out to you after this meeting and help you with the talk about caregivers and how to negotiate that if you need some extra support. Dom is shaking, nodding yes. So maybe you can help.
Absolutely. In fact, our April class or caregiver class is on recognizing and managing caregiver stress and those taking care of dementia patients. So that'll be on April 29, I believe. If anyone is interested in that class, just keep an eye out for that. Are there any more questions from our panel this morning? No, Pat, do you have any other comments?
Dr. Cole, just curious for something the families may be asking. If you were interested in questioning or asking your physician about palliative care, is it up to the family member to call their insurance company? Let's say I have Medicare and Blue Cross as my supplement. Would I call Blue Cross and ask them if they would pay for palliative care? Or would the office that I was going to, like Kindred or whomever, would they do that research for me?
Definitely, I would ask the company that's you're going to work with for them to do the research on your insurance. If you were to call Blue Cross Supplement for your Medicare and say, gee, will you pay for a palliative program? The answer is going to be no. And the reason is because since Medicare doesn't pay for it, your supplement insurance won't pay for it either. And your supplement insurance is primarily Part B, which is the 20% of the outpatient stuff that Medicare only pays 80% of. Hospice itself is under Part A, and so typically the supplement has very little to do with it. So no, I wouldn't call my supplement and say, gee, are you going to cover this? And they won't say no. They'll say, oh, well, go to Medicare first, and then whatever they allow, then we fill in the extra part. But they won't be honest and tell you straightforward, because they don't want to make you mad, that no, they don't pay for anything that Medicare doesn't already pay 80% of.
Okay.
So that answers
Sure.
why I got on. That answers why I got onto hospice. My doctor for a year was requesting palliative, and when the nurse came to interview us, we didn't get it. So it wasn't until the 4th visit that the nurse from Desert Oasis, it was my primary, that arranged everything. He asked for palliative. He didn't know why they gave me hospice. By the time we figured everything out is when I left, and then they put me on palliative. So, and then my neurologist offered to put us on hospice. So it was through through Desert Oasis that we got the hospice and the palliative.
Yeah, they do have the palliative care program for their senior members only, is how it used to be when I worked with them.
Well, I'm 39, so my husband is senior then.
All right. Thank you so much, Dr.
I
Cole.
see a number 3 under chat. Did we?
We got, yes.
We got those?
We
Okay.
addressed those, yes.
All right.
But thank you for keeping an eye out. And thank you so much. This has been super informative, but I really appreciate it.
Good. All right.
Thank you, Dr. Cole. Very
Thank
useful.
you again, Dr.
Thanks
Cole.
for spending an hour with me.
And thank